In this penultimate episode, I'd like to discuss something I value of the utmost importance: collaboration. This production has been fun to put on, and it affords us an opportunity to work together, support each other, and give something back that's bigger than just ourselves. Too often, I've encountered those in our field who are not oriented towards this value. There are people in our field who selfishly take and don't contribute. They're out for themselves and nobody else. If something were to happen to these videos, it's because of someone like this. Me, myself, I will always be looking for the light, to point to something bigger than me, to pave the path, and leave the world in a better state than I found it. Bond will always be oriented towards providing the best collaborative environment among healthcare providers. Without further ado, this week's episode. Enjoy. We can run through this one kind
Oh, 4 slides.
of. You're being facetious, Jones. It's only 4
Yeah,
slides.
I am.
Yeah. I don't even know how to go away. Let's play it. You want this one, Jones, since you're just confident in answering from the.
Yeah, exactly. Yeah, I'll take it.
I think you're actually going to do fine on this one, though.
Well,
Uh,
that's okay.
go in.
Oh,
Let's say you got a 47-year-old female. You are with Dr. David Isley at Hopkins, and he tells you you got this patient in the chair. She says it's getting hard to swallow lately, and she's having some trouble with the swallowing. What do you want to know?
HPI, so, new on history of symptoms. When did they begin?
Yeah. This began about 6 months ago. She doesn't really have any pain. Again, just trouble
Yeah,
swallowing, and
swa okay. Is she having any, any difficulty? You said swallowing, any difficulty breathing, any changes in,
not really. No
any
shortness of breath. No
any
dyspnea.
changes in, any numbness or any paralysis she's noticed?
No sensation changes. No changes in her function.
Okay. And has the swallowing progressed? Has it gotten worse? I mean, like, has it progressively gotten worse, or has it kind of stayed constant?
Um, the swallowing has progressively gotten worse.
Okay. And then just kind of her past medical history.
Yeah. She has, well, for this case, the medical history isn't too relevant, but
Okay.
diabetes type 2, she doesn't have any familial history of cancer or anything. And she's not on any, crazy relevant
Yeah.
medication. Um,
Okay.
you get
Well,
this image. What
yep.
kind of image is this?
This this is an MRI. This is a axial view of an MRI, um, which is, I think this is T1,
Yeah.
T1 weighted, or maybe, yeah.
Sure. What's the difference between T1, T2?
Well, T1, it's going to light up. Um, T1 fat will light up, versus in T2 more like fluid or water will light up.
Sure.
Um, Usually, yeah.
Um, what structure, if you had to guess, is the arrow on?
So this looks like we're at the level of, like, I can see
Like mid
I would say, like
like
posterior, like the junction between the nasopharynx and the oropharynx.
yeah, you're right at this level. I don't know if you can see me, but like right at the
Yeah,
um uh
almost like the, yeah, like it looks like right at the level of like the parotid,
yeah, yeah.
maybe
Is
just
this the
superior
deep
to,
or the
yeah.
superficial lobe?
What?
Is this the deep or the superficial lobe of the parotid?
This is the deep.
Um
This
what
looks like,
lobe of the parotid do tumors usually originate in?
Where you said? They usually originate in the superficial lobe.
Sure. Um, what's on your differential for this patient based on the information you have now?
Well, if this is a deep parotid lesion, then I would have um, um, so salivary gland pathology, including pleomorphic adenoma, um, as, acinic
Cell.
acinic cell carcinoma. Yeah.
Um,
Um, it would include, just squame or metastasis. Um,
sure. Would adenoid cystic be on your differential?
um, Possibly, but I think that occurs more on the palate.
Okay. Um,
Um, and
so
then
what would your plan for this patient be?
any type of soft tissue tumor, like a sarcoma or something of some sort.
Okay. Yeah, yeah, all fair stuff. What would your next step for this patient be?
I'd do a physical exam, starting extraorally, and um,
I feel like the
palp
physical exam's pretty nice.
palpating the extraoral functions, checking facial nerve
Yeah,
function.
yeah. Yeah. With regards to that stuff, she's all good. You've
Okay,
seen no evidence of ulceration, tethering. Um, there's, this appears soft. It's
okay,
non-painful.
yeah,
It is, she has normal secretions intraorally. Parotid function is decent. Good salivary flow from Stenson's.
okay.
Um,
I would probably then plan on possibly doing like an FNA
mhm. Um, so let's say you're
at the axis. Yeah,
yeah, to the deep lobe.
might be
Um,
a little difficult. Yeah,
I actually didn't think about that. Yeah, an FNA might be a decent way if you
but you
maybe
might or go
you could do it
intraorally.
early maybe.
Yeah.
Mhm. Okay, well, let's say you don't opt to do the FNA
Okay.
because you can't find a real landmark. She wants this taken care of and just removed. Um, she really doesn't care what it is right now. She says, "So what can you offer me surgically to get this so I can swallow normally?"
Okay. So assuming that it's a type of, I mean, I would like to know, assuming that it's a pathology, I'd like to know the pathology so I know if it's amenable to, resection versus, chemo or something else. But assuming that it's amenable to surgery,
Yeah, there's no
um,
evidence of being a high grade or malignant tumor.
okay, so it's benign tumor. Um,
How would you approach this surgically? Let's say it's a pleomorphic
yeah,
adenoma.
pro- probably would do an extra oral retromandibular retroparotid approach. Um,
Let's say for the deep lobe, let's say that you
with
do that, but it's a little tough to get to. You end up doing it like extending an incision,
Yeah,
retromandibular and submandibular, and you're just finding that it's really tough to get to.
well,
Is is
I
there
know that you can.
something? Yeah.
Yeah, I think you can. I'm trying to. I know you can do some type of osteotomy, basically to you can do
What
an
do you think?
osteotomy of of the ramus. I know, but I'm just trying to
ERO?
think. Yeah, and probably an IVRO or an EVRO.
Yeah. Um, cool. So you do that. You're able to take out the tumor. Everything goes just fine. We could run through structures. If we want to, but IMAX stuff and carotid stuff. This is your next patient of the day after you do that surgery.
Hmm.
What do you think is going on here?
Well, again, if I would ask about symptoms, I would ask about history of present illness, how long it's been there for.
He says it's been here for a number of years, just increasingly growing. It's not
Yeah.
invisible. He has
I,
no affect of his facial nerve.
okay. I'd ask about
He does smoke.
HPI, and particularly, I'd ask if he's a smoker.
Yeah, he smokes quite a good bit.
Okay,
He loves to smoke.
sure.
Can't
I mean, on my primary, I mean, the primary jumping ahead, the primary differential would be a Warthin's tumor,
yeah,
but
uh, sure. A Warthin's tumor, what would you recommend for this patient at this time?
um,
Like
I would find out. I
like
would probably plan on doing a superficial parotidectomy, um, but I would, if making sure that if it is bothersome to him, which it sounds like it is, um, I would offer surgical excision, the um, superficial parotidectomy by going through a facelift type incision.
Okay. Your next patient of the day, and thankfully the last patient of the day, has this going on.
Okay. Um,
She is infant female, and the parents are wondering uh, what it is and how it progresses and what can be done.
I would start by again asking for history of present illness. How long has it been there? When did it arise? Was there any history of trauma? Um,
Sure, no history of trauma. Um, this is something that she was she was born with. Um,
has it gotten any larger or progressively larger or changes in color or shape?
it hasn't really changed in shape. It's just been red like this.
Okay.
It blanches
Does
if
that
you really press on it, but it's not painful to her or anything.
It's not painful, it's non-friable, and you said it blanches. Is there any pulsation within it?
No pulsation within it, no bruise or anything either.
Um, so based on the age, based on I don't think any image. I think really just a clinical exam is all that's required for this.
Mhm.
Um, and most likely, I would probably say tell the counsel the parent that it's a hemangioma
Sure.
that are relatively common in infants and tend to self um, self control them or kind of burn themselves out, and sometimes will actually and then disappear.
So yeah, that was the parent's next question. Is it going to disappear?
To my understanding, yeah, usually they will regress. Is my understanding
Sure.
without treatment.
That's pretty good. That's all I got for you today.
They will regret. I mean, they do go away, right? Or
Yeah,
is there
yeah.
some, or
Yeah,
there's sometimes that they stick around.
so yeah, we can actually review this one first. This is an infantile hemangioma case I pulled up. Um, it's usually present on birth, rapid or it rapidly grows after birth. Uh,
Right.
most of them are in the head and neck region, mostly in females. Um, it follows a course of proliferation, involution, then regression. And I think it sticks around, like it may stick around up until like age 5 to 7. Um, like 5 to 7, it's almost 100% of them are, disappeared.
You
Uh,
say they go through involution. Sorry, they progress, then they
yeah,
involute.
it may grow up through the first year, but then it
Okay,
involutes and it regresses.
got
Um,
it.
it might start out as like a little macular red spot or a pale area, maybe a telangiectasia or ecchymosis, but then it goes away on its own. Usually doesn't ulcerate or anything.
Hmm.
Um, and I guess like there are such things as non-involuting hemangioma, uh,
Right.
which I think if you still see it, on a kid a little later, uh, if it's ulcerated, you can use a pulse laser. You can do intralesional steroid injections for small lesions like this. Um, I think there's also something with vincristine. I don't know that regimen though. I guess you could resect it too if it's big enough, but I mean, there's always the option of resecting.
Hmm.
Personally, in something like this, I'm just kidding. I wouldn't resect. Not here. But if it's big enough, it's nice to know. We have our blades. This was a Warthin's tumor. You're correct. Bilateral doughy. Doughy is really the word we're looking for here. Bilateral doughy, superficial parotid masses.
Hey yo, I gotta sharpen my swords for the oral boards. I learned him from Patel and he's the Lord. And I'm his protege, you know I'm gonna slay all these motherfucking questions today. Cause I got the sound bites, they're gonna make these old men go, ooh, ah, like some afternoon delight. Yo, I got these questions in my sight and I got the answers. Yo, my answers is so ill, they give you canker sores.
Thanks for tuning in to Oral Surgery Fight Club. For uncut episodes and sound bites, go to osfightclub.com.